Right. Okay,
Yeah, it's given me a message to say it's started.
great. Okay, well, welcome everyone to the PHreSH seminar today. Apologies for the problems with accessing this, but pleased that you've made it here. Really pleased to have Catherine Brown speaking today. Catherine is one of the, or I think you're the lead, aren't you, on the PHIRST
Yeah.
Connect, which is one of the NIHR-funded public health teams that works with local government to evaluate local government initiatives around, to improve the health of the public. And part of the work of PHIRST is understanding how evaluable these interventions are, because of course often public health interventions are developed without thinking about evaluation in mind, so that evaluation has to be sort of retrofitted to the program. So Catherine's got a lot of experience of undertaking evaluability assessment as part of PHIRST, and is kindly here today to tell us about it. So going to pass over to you, Catherine, some time for your presentation and then questions stroke discussion afterwards.
Thank you, Andy, and thanks for the invite to come and talk. So I'm going to see if I move the presentation along, hopefully. Okay. Hopefully you can see it move on. So just a quick overview. I've tried to keep slides relatively short so that we've got some time for questions, answers, discussion, commentary, etc. at the end. But I thought I'd just give a little bit of brief background on me so you can kind of understand a bit more about my history before working within the PHIRST scheme, explain a little bit about the PHIRST scheme for context, and then get into the sort of meat of things around our approach to evaluability and commenting a little bit on some of our challenges encountered and lessons learned along the way. So that's really what I'm going to kind of cover. So by background, I'm a health psychologist, PhD in health psychology. And within that field, I've focused on the development and evaluation of behaviour change interventions. So some of my first kind of evaluation experience came through the development and evaluation of my own interventions. But I've always been interested, right from PhD days, in theory and evidence being put into practice with a goal and a focus around improving health outcomes. For many years, I sort of started work in the field of sexual health, and particularly things like condom use in teenagers and contraceptive use in teenagers. So back in the days of the previous Labour government, and in particular, sort of started with teenage pregnancy prevention and that sort of area, but over the years progressed into working still in sexual health, but also much more broadly across a range of public health issues. And right from the outset, so my first kind of academic post was at Coventry University, and they had at the time two applied research groups with a health psychology focus, which were about interventions and intervention development and evaluation. And from the get-go was always pretty much working in partnership with public health colleagues or NHS trusts or other types of partners, so often in the third sector, as well, on the development of evaluations and the development of interventions and the evaluation of those. I had, from between 2011 and 2019, an embedded role at Public Health Warwickshire, so first as reader and then later promoted to professor while I was in that role, still working in academia, but spending at least a day a week of my time at Public Health Warwickshire in the office and working alongside colleagues there to do various things with them. So sometimes it was scoping out literature and evidence with them or for them, and sometimes it was about service development and certainly service evaluation as well as part of that role. And then I came to the University of Hertfordshire in October of 2019, so just over 4 years ago. And PHIRST Connect got going, not all that long afterwards, so from August of 2020. But I really just wanted to sort of outline that to my sort of experience around thinking about evaluation of public health interventions kind of goes back quite a long way. So although I'm going to focus a lot on PHIRST today, it sort of predates that, and I'm drawing on a lot of kind of experience working with public health colleagues on evaluation for many years. So the PHIRST, that stands for Public Health Intervention and Responsive Studies Teams. Just as a bit of background there are 6 teams nationally funded by NIHR. There will soon be 8. That's our web address if you want to kind of go and explore a bit more, understand a bit more about the scheme and what we're up to. And these are based at universities across the UK with a remit to work nationally. So we've always been asked to be prepared to work in any geographical location across the UK, regardless of where we're based. PHIRST Connect is based at the University of Hertfordshire, but we've got colleagues at several other institutions, so University of East Anglia, University of Birmingham, and Queen's University in Belfast, which helps with geographical spread, but we've also got other expertise such as health economics that comes from the team at UEA. And the purpose of these is to evaluate real-world public health interventions, and to do that very much in partnership with local authorities or other types of public health agency and their partners. The aim is that we're rapid and responsive, but also rigorous in terms of the approach, the methodologies and so on. And a really important part of that is being co-produced. So that doesn't just mean working in partnership with the local authorities, but also with members of the public. So inclusion of the public voice, really central and critical. I think our group in particular is strong on this. We have a very active public involvement in research group who are part of our team at Hertfordshire, a co-applicant who chairs that group. And every project also seeks additional input from local public members as well, who ideally have direct experience of the public health intervention service or whatever it might be that we're evaluating, and we bring their voice into thinking about every aspect of what we're doing. So developing the ideas for how we'll run the research, refining research questions. They help with sometimes data gathering, often data analysis, and certainly with helping us to make sense of findings and think about recommendations for practice. Another part of the remit, perhaps gets a little bit less attention, is that we're also trying, where possible, to build capacity for research and evaluation in local government and other public health agencies. So yeah, if we can do that as we go and produce useful outputs for continuing evaluation, that's definitely, you know, a tick in a box there and wanted. That web link that I've included on the slide there is just the current call for local government partners and public health agencies, if they're interested in putting in an expression of interest to be evaluated by PHIRST. It's useful to include that. And so get it to move on. It doesn't seem to be working very well. Okay, move it along. Okay, so this is the meat of the presentation now. So I'm going to talk a little bit about our approach with some reference to kind of current projects, completed projects and so on, and some of our learning. So in particular, we've drawn on 2 key published articles on evaluability assessment. These have been a bit of a cornerstone for us as a pivot point for thinking about evaluability. So what I know, Andy was involved in producing the Millbank Quarterly article there on assessing the evaluability of complex public health interventions, 5 questions for researchers, funders and policymakers. It's really useful. It's a very pragmatic article, which really helps you to focus in on some of the major thinking points in evaluability. But then also we've drawn on Rick Davis's review of relevant literature and then recommendations. And he talks about evaluability in principle and evaluability in practice, which is quite useful as well for sort of thinking about those 2 aspects and whether practically you're going to be able to achieve what you're trying to. there's a very detailed checklist that goes along with that article as well, several pages. I think it's 3 pages of sort of checklist items. We found much of it very useful, but it can be a little bit overkill as well in some instances. So drawing on both of those things is useful, as well as our own kind of previous experience. In terms of how we sort of get on and do this practically as part of PHIRST, so there's inevitably a series of meetings with project leads at the particular local authority we've been matched with, and they will often bring a set of relevant partners to that meeting as well, who might be those commissioned to deliver the particular service or intervention, or data holders, or other sorts of partners. Obviously, it's important to sort of meet with them and understand who's involved, what voices are in the mix. This is a sort of iterative process that sort of then goes around for a while in terms of internal team meetings, discussing what we've learned, the implications of that. We consult with our PHIRST wide advisory board, so we meet with them 3 times a year. So often we would seek some input and some advice from them when we're thinking about a new project that's been assigned. And also our public involvement in research group, they meet every month, so we can often take thoughts and ideas to them as well, and get them to sort of reflect and bounce back their thinking. And then usually what happens is new stakeholders kind of emerge through this process as well, that we think, we need to consult you. You're going to have some really useful and relevant insight here into what might work, what's going to be practical, what's going to be feasible, and so on. So that tends to be a fairly iterative process. On paper, at least, the NIHR likes us to try to complete this kind of evaluability process within around 6 weeks or so. In practice, it can take longer than that. And ideally, they want us to try to reach the point where we've got a protocol within 12 weeks of being matched to a team. Sometimes we've met that turnaround time without any issue. But when there are kind of multiple projects on the go at the same time as running evaluability assessments, it can take longer. And of course, the partners themselves will have a lot of capacity issues, juggling multiple pieces of work. So timeframes can get a little stretched, depending on kind of local authority and partner capacity as well. So through that process, we're sort of attempting to establish these key points. And I've got like a slide or so against each of these points. I'll go into them in a bit more detail. So, but essentially, we're trying to establish what is the intervention. Is there any existing evaluation that already exists? Perhaps it's been done locally that we can use as a bit of a starting point. And indeed, is there other things that are kind of going on nationally, or have gone on nationally or elsewhere, that would be useful to really look at, draw on and build upon? And indeed, it might be that an evaluation isn't that necessary because of other things that have happened. What do the partners want out of an evaluation? And how's that going to inform their practice or policy locally, but also potentially wider than that? How important will it be beyond that local authority or that particular geographical location? What's the size of the population who's going to benefit? And particularly for PHIRST, we need to think in PHIRST terms and think about how PHIRST sized the project is. I'll give a bit more information about that. And is this going to be at the right time to conduct an evaluation? And is it possible to conduct the type of evaluation that's wanted within the sorts of timeframes that we're able to do it in? So we're kind of balancing all of these things within our thinking and our decision making. So first of all, what is the intervention? So we really try to get as much as we can from the local authority partners as early as possible. So obviously we ask them for existing descriptions of what it is that they've done, that they may have in written documents and so on. If they've already developed a logic model, and sometimes they have, or expressed the intervention in some way, in kind of written or visual format. And we're also really obviously listening to staff verbal explanations about what they've done as well, to add to that thinking and understanding from any written literature. And something that we're kind of learning over and over again is that often the intervention that's described initially isn't quite what it seems at first. There may be hidden layers there, things that they're not describing to us straight away, or not even necessarily fully aware of themselves. Obviously, in the way that public health kind of works is there's a system that where often there's commissioners in the public health context, but then there's different people on the ground delivering things, and things can shift and change and be quite different from what's intended. And it's our job to sort of pick through all of that data and information to really try to get to the best possible understanding about what the intervention is. And this hasn't happened within our PHIRST yet, but there have been several PHIRST teams who have said no and rejected an evaluation at some point during the evaluability process. And there was one PHIRST team that had had a number of meetings and evaluability workshops with the local authority and partners before it transpired that they hadn't actually developed the intervention that had been submitted as an expression of interest yet. So I'm not quite sure where the communication kind of broke down or didn't quite work out there, but there has been an example of that. And certainly what we've learned a lot is that the intervention can change quite considerably from what comes in at the expression of interest points. And that's part of public health in the real world. Things change, people's capacity changes, what's needed changes. And public health departments and their partners are, they're trying to meet demand and work with an evolving situation often. And a recent example of that is we've recently been working on evaluability for evaluation of health checks in Derbyshire. So obviously health checks are a statutory requirement of local authorities in England to fund those as part of a sort of national programme of health checks. Anybody over the age of 45 up to over 40 up to 75 is eligible for one of these. So there's a potentially huge population of people who stand to benefit from health checks. And Derbyshire have been implementing changes to the way they deliver health checks in order to try to improve things like uptake of them and outcomes from them. But the initial proposed changes that they came to us with haven't actually transpired in quite that way. So they were proposing a shift to a community delivery model, and actually that's not what's happened in the end. They are mainly delivering still in GP practices, and what's actually ended up changing is that their Live Life Better Derbyshire team, a health promotion team, are delivering health checks in 10 pilot sites. So a different delivery model, but not the one that they'd sort of come to us with originally. And they'd also proposed to do some co-production work with particular target groups that hasn't actually transpired. And instead, they've been doing some different changes around implementation of text message prompts and reminders, changes to letters, and an online booking system. So what we're actually going to end up evaluating is quite different from what they brought to us in the first instance. We've sort of had to go on a bit of a journey with them around that particular issue. What is the intervention? Thinking about whether or not there are similar evaluations that we need to learn from. We obviously want to avoid reinventing the wheel and not just reproducing things that are already pretty widely known or pretty well understood. And we're interested, obviously, in anything that they've done locally. In the Derbyshire example that I picked up on before, they had done an evaluation of some of their pilot work already. So we picked that up, we've absorbed all of that and tried to design something that builds on what they've already learned from that process. And we're also obviously interested in what more national or international evidence might exist, any national projects that sort of ongoing or happening that we might draw on. As it happens, another PHIRST team are currently doing an evaluation of digital health checks in Southwark. So we're obviously keeping a keen eye on what they're up to. The team in Derbyshire don't have digital health checks. They haven't been implemented locally for them yet, and they don't yet know when they'll happen. So we're just keeping an eye on that. And as well as obviously being keen to meet what they need at the local level in Derbyshire and what they want to learn and get out of an evaluation, we've also got an eye on, what will if we run this study, what will this contribute to the wider body of knowledge, and sort of taking account, there's been a lot of research done on health checks nationally, and we're aware that there's already a lot of evidence about text message prompts and reminders making changes to invitation letters and the difference that makes. That's pretty well established already. So if that was the only change they were making, we probably wouldn't be keen to go ahead with an evaluation. But much less is known about the difference that's shifting the provider model away from the standard of care GP practice delivery. What difference that might make has been much less evaluated. So our assessment at the moment, at least, is that does make a useful additional contribution to the literature in this area. And then just picking up on a couple of other projects. So we ran our first and second project were both focused on moves to remote service delivery that were necessitated during the pandemic. So with drug and alcohol services in Leeds and with the Welsh National Exercise Referral Scheme. Obviously, these are services that are by and large delivered face-to-face, or were by and large delivered face-to-face pre-pandemic times. And they moved to, like many services up and down the country, an unprecedented remote offer during the pandemic. And that was obviously, in terms of similar evaluations, there hadn't been that opportunity to evaluate the impact that sort of change in service offer had on people. So those offered real prime opportunities to gather evidence on something that hadn't really happened before, and to get that into the public domain. So a whole raft of publications are sort of out and in editorial at the moment from both of those studies, which we hope will be well received. And then I think this, for me, is often one of the most important questions. What did the partners want out of the evaluation? Because this really feeds into lots of thinking about, is it process evaluation? Is it outcome evaluation? Indeed, is it economic evaluation? Or is it all of those things? And getting the evaluation questions right, we pay a lot of attention to that and iterate considerably around all of the different stakeholders and partners to try to really get those right for the local authority and for the wider evidence base. We're thinking about how it's going to be useful for wider practice and policy. Will others be interested in this? In terms of the local picture, it's really understanding the intention of those local partners for how they're going to use that evidence in practice or to influence their local policy, but also what's the potential for wider scale up. And our discussions are often focused on trying to help them be quite clear about that, because that's important for us as well if we're going to have impact from the research. And it's not unusual for them to not feel clear about this to start with. So they know that they want an evaluation, but they're not necessarily always 100% clear on why or how they're going to use it. So we do try to sort of have a pathway for potential impact sort of mapped out as early on as possible in the process. And as I said, we're thinking about what's the potential for wider impact. How useful or important could this study be for other local authorities, other public health agencies and their partners in the national picture and potentially an international picture as well. And if we can identify there's good potential and we think we can practically deliver the work, then of course having a clear dissemination and impact strategy will also help us to get there as well. So as I said, we're all thinking about that along the way. Nice recent example of this kind of panning out reasonably well so far, and with a lot of legs, I think, is we've done some process evaluation of a whole systems approach to tackling diet, healthy weight, and obesity in the east of Scotland. And that work has had a direct impact on plans in Northern Ireland to do the same thing, and a lot of the learning about the challenges in making that happen, and particularly some of the challenges that COVID presented for making that happen, although they're a sort of unique context. They do talk to the potential for, you know, crises to emerge and things to need to pivot. So it helps to highlight, you know, where you need to think about the danger zones in rolling out and delivery, building something like that. And that's having a direct impact on plans in Northern Ireland. It's a nice example of it coming full circle, because we've now been assigned to work with the team in Northern Ireland on their whole systems approach to diet, healthy weight, exercise, obesity, etc., and to do some ongoing process evaluation of sort of the process, but a little further along on its journey. So we'll be really helping to build some of that evidence around how to do that well, where potential pitfalls are, etc. And I mean, I've learned this often in my kind of journey of working with public health, but it's really important to understand whether all of the relevant partners and stakeholders also want this evaluation to happen, and to sort of figure out if you're going to get their support, and whether relevant partners and stakeholders have got the capacity to genuinely be involved. We've come a little bit unstuck at times on a project with Lambeth Borough Council and their partners around delivery of projects from the Public Health England Better Mental Health and Wellbeing funding. We ended up doing a relatively retrospective evaluation using a realist approach for this particular project. And sometimes that's led to lack of capacity with certain partners and stakeholders because they've moved on, the funding is over for them, and they don't see quite so much value in being involved as they might have done earlier in the process. And there's also just, as is often the case, a little bit of reticence sometimes about what, you know, what does being evaluated mean? Are you going to be potentially finding things out that I don't necessarily want shared? And so we have to work quite hard sometimes, even after things have gone through evaluability, to reassure people and to work in a cooperative and positive way with them, so that they don't feel that reticence so much. And we have largely overcome some of those challenges for that project, so that's been okay in the end, I think. What's the size of the population who may benefit, which is a sort of standard evaluability type question, but it has sort of extended parameters, I think, for us, because we're trying to create first-sized projects that are going to work within the scheme. So we're thinking about the size of the population who receive the intervention, and whether that's a sort of a big enough population to mean that it's the right time to evaluate that particular service or intervention. But sometimes it can be a sort of smaller population if it's a really meaningful issue, which could have wider implications, even if you are only gathering data from a relatively small population. So one example I can think of that's kind of come through the books, it hasn't necessarily been signed off as happening, and it may not, but it's made it through initial checks at least, is a very small scale project looking at solutions for homelessness, and the people that are being worked with on that issue are very small in number, but it's a really critical issue with a lot that needs to be learned in terms of how to address, tackle and solve problems around homelessness. So it could be that one does go through and gets matched with a team and passes evaluability because of its kind of importance as an issue and a topic and the need to build evidence around it. But typically interventions can't be too small or too niche, and they'll often not kind of get past the initial expression of interest stage at NIHR if they are too small or too niche. But they can't be too large scale either. So PHIRST isn't really able to deliver randomized controlled trials, not usually a suitable design anyway, but also we need to really be able to understand intervention effects or processes, typically with relatively smaller numbers of people than that kind of study would allow us to, although where we can access existing data sets, we can potentially, you know, get tens of thousands of people's data by which to ask questions and evaluate. So it's a sort of flexible issue, and it can really depend on the project, but it's something that we're thinking about at the evaluability stage. Who, size of population affected, and then whether it's going to work in the sort of first scheme of things. A recent sort of example of where we've met a challenge here was trying to evaluate green health prescriptions in Scotland. I think we were led to believe that it would be possible to do a reasonably sized quantitative evaluation using a pre-post design. So we couldn't even really go into the realms of quasi-experimental design, but trying to gather data at baseline and at follow-up for people who've been given a green health prescription or a green health referral, to gather some quantitative data about the effects on them in terms of improvements on certain outcomes. But actually, once we got into it, there are some real problems with the system and the way that referrals happen and the way that the system is able to reach people, which have meant that actually ultimately the quantitative pre-post design just really hasn't worked at all. It's been really hard to recruit people. And we did push at this issue in the evaluability stage, but we kind of got assurances that, yeah, we could do this, this could work. But ultimately it hasn't been successful. So yeah, despite our best efforts there, fortunately we've got a really good piece of qualitative work, which I think will give some really rich data as well. So a bit of a shame, but you know, it's chalked up as a lesson learned. And then the last kind of point really is around whether it's the right time, and can we, and this sort of talks to size as well, size of project, but can what we're thinking is wanted be conducted in the sort of first time frames in the scope of that work. So we make a decision as a team and in partnership with partners in the local authority or the public health agency area, and we're asking, you know, key questions about, is it possible to collect or access, or both, data that allows us to answer the kinds of questions and measure the expected changes that we've understood through our work there. Existing data is incredibly useful, but it does present challenges. So we have encountered significant delays when we've needed to get data sharing agreements sorted out, for example. And even once data sharing agreements have been sorted out, there can still be delays if the project partners have to prepare data in a particular way that's different from how it sits in their systems, for example. So yeah, it's great to get hold of that data, but it doesn't make it easy necessarily to do the evaluation, and it's rarely sufficient on its own for a good evaluation to just look at that existing service data. So we would always want to be augmenting that with other types of data collection. And of course, collecting new data is resource intensive and can be difficult to achieve, as with that Scotland Green Health prescription example, where we've really struggled with getting quantitative data collected. So we do have a bit more than 74 days, 20 hours, 23 minutes and 54 seconds in which to do first evaluations, but the time frame is typically with between 12 and 18 months in which we need to do the work. So it all has to be possible within that sort of time frame, ideally. And then just to give you a slight flavour of the methods we've ended up landing on as a consequence of evaluability assessment over our time at PHIRST, we have done some evidence syntheses, although I've sort of put a stop to those because as time's gone on, we've realised we don't have the resource to kind of keep doing those, and they're not the most important feature. They can be really useful and obviously contribute to evidence, but yeah, we're not commonly doing those. What is quite common is forms of mixed methods evaluation, and those will often obviously have a range of qualitative methods involved. So we've used, obviously focus groups and interviews are very typical, but we've also trialled interactive timelines, asynchronous, text-based or email-based interviews for particularly service users with vulnerabilities who might find that easier than talking face-to-face or online. Vignette production. So we did that with sex workers in Leeds for the drug and alcohol services evaluation. We did interview sex workers as well, but another way of trying to get their voice into the qualitative data was to ask staff to hold conversations in the normal course of their work, and then come and create vignettes that covered the sort of range of experiences that they'd heard from their service users. And that helped us to really pull those experiences into the data set. Quantitative, obviously, part of the mixed methods approach. So we're often using existing data sets where those are available, but certainly, on some occasions also collecting our own data, particularly survey data, where we find that would be useful. There's been a lot of process evaluation as part of this as well. So process evaluation often typically uses qualitative methods again, so focus groups and interviews are a key feature, but we've also used ecological momentary assessments to try to get data over time in a longitudinal way. And something that we're still grappling with at the moment is causal loop diagram production with an expert in systems dynamics to look at the sort of interactive feedback loops. And this was to do with the whole systems approach work in Scotland, but to look at how the different sort of actors and actions in that process of setting up a WSA, how those different actors' actions kind of interloop and feed back on one another, to create a complex system of setting up a whole systems approach. We've used realist evaluation on a couple of projects as well, and that's been really useful, particularly in those kinds of interventions where the intervention is not a solid thing that you could produce a manual on. It's something much more sort of diverse and fluid than that. So the mental health promotion work is one. And then we also looked at COVID champions, vaccine champions, and community participatory action research during COVID. And of course, those kinds of interventions rely on lots of different people doing different things in different spaces and communicating in different ways. And so a sort of much more dynamic, pragmatic approach to understanding intervention processes and effects seem to fit and work there well, and has been quite successful as an approach. And then something we're about to try for the first time, so I can't comment yet on how well this has gone or will go, but something called real sheets, which are rapid evaluation assessments devised by a group at UCL, but it sort of is based off an approach that my colleague Katie Newby, a co-applicant in our PHIRST, has used in evaluations with public health teams previously. So it's quite similar to an approach she's used similarly. And we're going to apply that in our evaluation of Northern Ireland's whole systems approach to tackling obesity, diet, healthy weight, etc., which won't really get underway until the new year as a project. We're in the evaluability phase on that at the moment, but it looks like it will go ahead with that approach. I think that's all of my slides. Sorry, there's not a huge amount of time left for questions, but there is some, so very happy to take some and yeah, just hear other people's thoughts and comments as well.
Thanks for that, Catherine. That's absolutely fantastic. Well, maybe if we stop sharing, then I can see everybody on the call. While people have a think about other questions, I'll just take the chair's prerogative and ask the first one, which is around the issue that you raised around varying expectations of what the evaluation's going to, but both in terms of concerns over will it make us look bad, but also more fundamentally, why does the local authority want the intervention evaluated? And I'm just kind of interested in what the motivations are for actually submitting to the PHIRST in the first place, and how that sort of links through to what people actually want want to get out of it. If that makes sense, because there's actually quite a barrier, isn't it? You've got to fill in a form. There's a bit of work, there's a bit of legwork involved in getting into that process. So what are the sort of drivers of that?
So the drivers, I think, are about as many or more than the projects we've had through so far. I think I've encountered a real variation. I think sometimes there's a little bit of, we want an evaluation because we know that that's a good thing to do, and and the thinking isn't necessarily that clear about what they want out of it. But in other instances, the commissioner is very clear. I want some solid learning out of this process, this experience, this attempt to do things that are a bit novel or a bit different. I think that's often the driver. They're doing something novel, they're doing something different, or they're making a change, or change has happened, as was the case in the COVID context with the services there. And they're aware that there's learning that they really want to get out of it, but they don't feel like they've got the capacity or any of that kind of resource that might be needed to really dig into the experience and pull it out and then set it out in a really clear and kind of logical way in terms of all of the different routes to finding that and hearing all the different potential voices. With the work we did in Leeds, the drug and alcohol services, we talked to such a wide range of people about their experiences amongst staff, in different partner organisations and amongst different types of service user, and really pulled out rich information. So they're aware that there's no, even though they could get bits of feedback, on the standard evaluation sheets about what was good, what people didn't like, there just isn't the depth there. So they want that depth and that quality to come out.
Okay, yeah, that's interesting. Any questions from the audience? If you do, raise your hand.
So some things in the chat, just noticed.
No, I've put some stuff in the chat. All right, so if there aren't any, I've got loads of questions actually. So I'm also interested in which is not really, I mean, I guess in a sense it's not evaluability assessment, but it is a component of evaluability assessment, which is what will be done with the findings. What, again, it's sort of driving that through. And what's your experience been for those evaluations that are completed, in terms of what happens next?
Yeah, so there's sort of two that have been finished for over a year. So the first two projects, which were those remote delivery with drug and alcohol services and the exercise referral scheme in Wales, they finished just over a year ago. And one of the things we've been aiming to do is go back quite regularly to teams once we complete to find out how they're using that information and how it may be having impact. So with the drug and alcohol services, they took quite a bit of our findings and plowed. I mean, this was, I think, the direct intention of the commissioner who brought the expression of interest for this one. He wanted that evidence about what's the impact of remote delivery on the services, on the staff, on the service users. How do we plough that back into our renewed commissioning specification and our recommissioning of drug and alcohol services? So they very clearly put a lot of the findings into the tender recommissioning specification and directly asked the service providers, and they were very happy with their existing service providers. So I don't think there was ever any real issue that service provider was going to get gazumped, as it were, for somebody else, because they were really happy with their provision. But we're really clear about them needing to attend to the findings within their service redesign around the benefits of remote, but also where some of the danger points were for certain service users and service user groups. So that they have ploughed that into their thinking, and they've retained some remote service delivery as part of that service based on the identification of some of those genuine benefits for some service users. And then with the National Exercise Referral Scheme, in fact, one of the sort of key people from the Welsh team there is going to be part of a panel discussion at the next PHIRST seminar on the 5th of December, which is going to be a lot about lessons learned from the pandemic, what we're doing with public health differently. And there were quite a few key findings from the Welsh National Exercise Referral Scheme evaluation and their remote delivery, which highlighted the fact that in general, and included in remote offers, there are some real issues around health inequalities, and those needs, you know, in terms of who the service reaches and who it manages to pull through its doors. And actually remote can help to tackle some of that. So some people who would previously be excluded without a remote offer can now be included. But there are also challenges around digital exclusion to consider at the same time. So they're in a process of redesign of the National Exercise Referral Scheme in Wales, but they're very much taking account of what those evaluation findings shown in terms of thinking about how to reconfigure and manage those issues.
Okay. Once again, I give others an opportunity if anybody has a question or comment. Any reflections on your own work? Doesn't look like it. Okay, well, I've got another question. This is very indulgent. So in a sense, you know, as you've suggested, Catherine, you know, the evaluability, you're probably doing a sort of middle tier evaluability assessment in terms of the time and resource that you've got. You know, you could do more, you could do less. Is there and I know there is stuff out there, but I mean, one of the risks, isn't it, is that things that never would have legs make it through to a stage where, you know, I don't like to use the term wasting time, but you know, you're trying to revive the patient when the patient's long gone, and is there a need for use in local government for a sort of quick and, I was going to say quick and dirty, and maybe not, but some sort of really rapid evaluability assessment, just to sort of be able to almost have a green and red light coming out of it to help local government colleagues just figure out whether things are likely to have legs and whether it's worth progressing.
Do you mean it very specifically to going into the PHIRST scheme?
Well, yes and no. I mean, I guess I don't in a way. I mean, I guess the question is specifically to the PHIRST scheme, but I think it could be more widely used. Just that sort of, is this worth taking further?
Yeah, and well, I mean, I think those 5 questions that are in your Millbank Quarterly article are really helpful. You know, if you've not got a lot of time and you've just got to think about some of the key fundamental issues at play in this, then you know, that's just a brilliant starting point. I think it's been adopted quite widely by PHIRST, you know, other PHIRST teams draw on that paper as well, and I think I've already shared with PHreSH the form that we kind of use in that in our, you know, in our evaluability report to NIHR. I've actually added a couple of things to that, so I could send you my most recent sort of thinking version on that. But actually, the questions on that as well could be key indicators just to help think through: is this likely to be a goer for an evaluation? Or is it not? But it's almost something you can never be 100% sure on, because even the smallest scale, you know, in terms of the number of people who are perhaps being part of a pilot or something that public health colleagues are testing out, you could almost always do something that's process and formative evaluation on something that is quite early days. And even if that's just for yourself and your internal team, you're going to learn from that process. And you know, getting feedback from service users, that's always useful and valuable. Getting feedback from staff about, you know, where the pinch points are, what's problematic, what's challenging, what's really niggling them, or that kind of level of evaluation is always worthwhile, I think. And it doesn't need to be first fitting, you know, in order to be able to do something useful locally to help build your knowledge or understanding and move on. And I think there's a lot of expertise within local authorities about doing that kind of formative feedback, learning as you go, kind of cycles.
I think one of the challenges is taking that expertise and making it available to all, so it doesn't sit in certain teams within local authorities, but actually, you know, practitioners on a day-to-day basis kind of either know where to go or know what to do, and that's one of the things that's missing at the moment. But
absolutely. Absolutely.
Well, fantastic. Thank you so much, Catherine. This has been amazing. It's been really good to hear your experiences and lots of practical advice for us to take away and, you know, apply in our own work there, I think. Yeah, and thanks very much for coming along and talking. As I say, we'll upload this on the website. Desmond's also put a link to the newsletter in the chat if people aren't already signed up. Yeah, I hope everyone has a good rest of day.
Thank you.
Thank you very much.
All right.
Bye
Bye
bye.
for now. Bye now. Bye.
Bye. Bye.